All right, everybody, welcome to the second installment of Coach's Corner. This is something that we have started uh, as a way to get information throughout our sports medicine community and to build relationships and hopefully have some fun along the way and learn something. Um, we've been lucky enough to be partnered with the IHSAA for this webinar, and they've been good enough to uh, really coordinate the invites of getting you all the information about what we're presenting. We also want to make sure you know how we interact. So uh, typically we'll have a different specialist each month with a different topic. These topics will be pertinent to athletic trainers and to coaches and administrators in ways to keep our athletes safe and healthy and more successful. During the presentation, you can ask questions. So there's a chat function on Teams, so you can use the chat function, ask whatever questions or comments you have. I'll be monitoring that, and at the end of the presentation, I can go through them and hopefully get some good answers to your comments. We are also sending out a post-presentation evaluation, so we would love feedback from these sessions, not only for each one specifically, but also for comments about future topics and information that you might want to hear about. Today, we are lucky enough to have Dr. Wohler. Dr. Wohler lives in Indianapolis with his wife and 3 kids. He enjoys actually brewing his own beer. So I think maybe another night we will have a nightcap webinar to discuss how the heck you do that and what makes it good. That would be fun. He did his medical training at Wake Forest. He did his residency in the Carolinas at the medical center there, and he just finished up his foot and ankle fellowship at Baylor in Dallas. So he joined our practice this year in September and has been enjoying his first few months on the job, if you will, on his own. So he's agreed to talk to us today about stress fractures in the lower extremity. So Dr. Wohler, all yours.
Awesome. Thank you, Scott. I'd like to say thanks to the IHSAA for the opportunity to kind of give this talk. I hope that you find this information useful. Like Scott said, I'm new to Forte, just starting up, and I spend time in Greenwood and Bloomington. So if you have any patients with lower extremity injuries, feel free to try and send them my way. Brief outline of what we'll be going through, some epidemiology and just kind of information that's pertinent to stress fractures kind of in the lower extremity in general. And then we'll go through a little bit more specifics of kind of common locations and what treatment and recovery and those kind of things look like. Trying to gear this to information that is useful for kind of a larger audience that's seeing players and athletes on a daily basis. But briefly kind of going through some of the epidemiology, stress fractures account for about 10% of all sports-related injuries. And over 90% of these occur in lower extremities. And so a very common site to kind of see stress injuries. When looking at the athletic population versus kind of general population, 98% of stress injuries occur in athletes. And so this is something that we see frequently. The incidence of these is greater in high-risk sports, where sports such as running, where the incidence approaches approximately 30%, as well as in elite athletes, where the rates are 20% compared to about 1% in recreational athletes. And so usually if you're playing sport enough and you're exposing your body to these kind of stresses, you have to be on the lookout for some of these injuries. Historically, these fractures have been, we've kind of tried to classify them as high risk or low risk, with the delineation between those being kind of high risk fractures that have a higher predilection for fracture propagation, non-union or delayed healing. So ones that are, you really worry about from a clinical standpoint that they won't go on to heal, or that your athletes will be out of sport for a long time as they recover. Lower risk fractures are ones that, when managed appropriately, have a relatively reliable healing pattern. Some just basic diagnostic kind of history and exam pearls if you're ever evaluating somebody or an athlete comes to you complaining of pain. These tend to have more kind of insidious onset that tends to ramp up over 2 or 3 weeks and then kind of persist and maintain. Rarely do athletes come complaining of a specific injury, but more just kind of gradual pain that increases and then becomes worse when they're active. Frequently, this will coincide with a change in either the training regimen, increased frequency of training, or training with new equipment and new shoes, new activities, those kind of things that place different stresses on the body than they had previously been subject to. The most kind of the hallmark physical exam finding that is present 100% of the time when patients have stress fractures is kind of tenderness directly over the affected bone and tenderness kind of right at the area of the stress fracture. It's also possible in the lower extremity to kind of test these and do functional testing, hopping on one foot, running, those kind of things that will stress the bone and lead to the similar symptoms that patients complain about. In certain areas like the metatarsals or the malleoli where there's not an abundance of soft tissue, you can often notice kind of localized soft tissue swelling as well. However, this isn't kind of 100% of the time going to be present. Turning to imaging and how do we work these up, right? So if you walk into an orthopedic surgeon's office, you're almost always going to be met by the rad tech kind of taking you back for x-rays before you get an opportunity to see the doctor. And so this is our first line screening tool. The most important thing to know about plain radiographs is that findings on x-rays will characteristically lag behind clinical findings. And so it's very common and almost expected that if patients have had symptoms for a relatively short period of time and we get x-rays, you may not see anything initially. And so it's important to maintain a high kind of clinical suspicion for these injuries. Often, if kind of the rest of the exam checks out and kind of concern for a stress fracture, we'll have patients come back at 2 weeks and repeat the x-rays, at which point you can sometimes see some of the findings of, early callus formation or kind of periosteal remodeling. MRI is the most sensitive and specific imaging modality. And so I'd say in elite athletes, if you're suspicious, this is usually what people are going to turn to first. Also can be very useful in the setting of radiographically occult stress fractures that you follow and just nothing is showing up on the x-rays. Bone scans have historically been used. They don't play a big role in my practice, as I think that you get less sensitive information than you get from the MRI, and that's kind of the first spot that I would turn. Generally thinking about ways to optimize healing in patients. Obviously, if you see anybody assessing their diet, and athletes in particular are subject to having caloric needs that are not necessarily being met by their caloric intake just because their output is so high. So making sure your athletes are eating enough and that their kind of building blocks of macronutrients are being met. Female athlete triad is very common. So amenorrhea, eating disorder, and then low bone mineral density, particularly places female athletes at high risk for certain types of stress fractures. Medication history, there are certain medications that can interfere with kind of absorption of calcium, vitamin D, and kind of optimal bone healing. And then this is kind of more probably for our adult population, but malabsorption or history of gastric bypass that can limit kind of nutrient retention for healing these fractures. Say anybody who's seen in my clinic that has one of these, we'll talk about kind of optimal bone health and kind of supplementing vitamin D and calcium. So recommendations of 2,000 international units of vitamin D and then 1,200 milligrams of elemental calcium. And then I think bone stimulators are plus minus the data on them. There's been some smaller studies that show promising results, but I think still some of the data is mixed. And so a tool that you can use for your patients, but I don't know that it would, or your patients or your athletes, but I don't know that 100% of the time it's going to lead to optimal healing. So looking a little bit more specifically at some of these fractures that we talked about. So high risk fractures, things that you want to really kind of keep a high clinical suspicion for. Anterior tibial diaphysis, so kind of right mid-shaft tibia fracturing anteriorly. Navicular stress fractures, fifth metatarsal base, sesamoids, and then medial malleolar stress fractures. Those are the ones that even with conservative management can be kind of tricky players. Low risk fractures are metatarsal shaft, distal fibula, kind of posteromedial tibial shaft, which we won't cover in detail, and then calcaneus. So tibial stress fractures, and this is kind of the anterior tibial stress fracture. If you've ever heard the kind of dreaded black line, this is what clinicians are looking for on x-rays, and it's this finding here in the top right where you start to see this crack in the front part of the tibia. You can see, if you look, normally the cortex, kind of the thick part of the bone in the tibia, should be about the same thickness in the front and the back. You can see that there's remodeling that's already starting to occur in that tibia because of the chronic stress. It's a tension-sided injury, so on the front of the tibia where the muscles in the back, and kind of subjecting that to more strain. Looking at a couple studies that have kind of followed these when they're trying to be managed conservatively, Beals and Cook let 8 patients kind of try and play through these. 5 of those went on to complete fracture, and so that's the risk if athletes continue playing, is that you can turn what potentially could be managed conservatively into a 100% operative fracture. Out of 20 patients that were treated with rest and kind of conservative care, 8 were able to return to sport an average of 4.4 months, but the remainder took longer. And so, even with conservative care, it takes a long time for these fractures to heal and patients to get back to sport. Art Rettig and several other colleagues from this institution looked at 8 basketball players in 1988. They were able to achieve union in 7 of those with rest and electrical stem, kind of bone stem. But the average treatment time was 8.7 months, and they didn't return to sport for over a year, which obviously begs the question, is this the best we can do for athletes? You're out for at least a season, generally part of the next season, before you're able to really return back to sport. So there has been a push to treat these surgically. Traditional surgical management is intramedullary rod versus anterior tibial compression plating. 2 studies kind of highlighting those. The first one was looking at patients treated with intramedullary rods. They had clinical healing at 2.7 months, radiographic healing at 3 months, with return to sport at 4 months, so quite a bit faster than conservative care. And then the second one was depicted here on the right. This is kind of anterior tibial compression plating. 13 fractures treated with similar kind of return guidelines, 9.6 weeks, 11 weeks for radiographic healing. And the majority were able to get back to sport at pre-injury competition levels. I think when you talk to surgeons about one or another, they'll have a preference. There's a little bit higher rate of hardware removal with anterior tibial compression plating, as there's not much soft tissue on the anterior aspect of the tibia, and the plate can often be symptomatic. But that's kind of briefly looking at those treatments. 5th metatarsal base fractures. This is something obviously that I see relatively commonly in my practice. Studies looking at NFL players have found a 2 to 4% incidence of either acute or chronic kind of stress fractures in NFL players. The historical non-surgical management has been non-weight bearing in a short leg cast or boot for 6 weeks, with kind of most of the studies looking at non-weight bearing in a short leg cast. After that, it's typically progressive weight bearing based on symptoms and radiographic healing. This was the first study by Yates et al. Was a meta-analysis, so kind of looking at lots of different studies, and they found non-union rates in patients who were treated without surgery ranged from 11 to 50%. So decent proportion of these that don't go on to complete union even with conservative management. And that rate dropped to between 0 and 11% with surgery. So there has been a push within our field to be a little bit more aggressive treating these early, particularly in the athletic population, knowing that they have a little bit of a disposition not to go on to complete union. Dave Porter and several others published this study looking at patients that they treated with cannulated screws, all of which achieved complete union within several months. Kind of looking at the surgical treatment for this, typically it's been percutaneous screw fixation, which is what's depicted in those x-rays there on the right side of your screen, versus plating. For patients that have chronic fractures or have had non-unions, there's a discussion of using kind of bone marrow aspirate concentrate or some type of autograft to try and augment healing and get good kind of healthy biologic bone in there to stimulate the healing. Post-op recovery, it tends to be non-weight bearing in a splint for 2 weeks, touchdown weight bearing in a boot between 2 and 4 weeks, and then weight bearing is tolerated in the boot until week 6, with gradually weaning back into regular shoe wear. I think the advantage of fixing these surgically is that often you're able to get athletes back to sport or back to participation quite a bit faster than if you are immobilizing them in a cast for 6 weeks and trying to progress from there. By 8 weeks post-op, patients are in regular shoes and beginning a sport-specific progression. Navicular stress fractures is probably, if you've been practicing foot and ankle surgery or sports medicine long enough, these are kind of dreaded injuries that no matter what you do and how long you follow them, they tend to surprise you. Multifactorial, they're thought to be due to chronic overuse and relatively poor blood supply. The picture on the top right kind of shows it's a micrographic portal showing the blood flow, and you can see that central area dorsally that just doesn't get much blood flow, and so that's thought, and that's the hypovascular zone that kind of limits some of the healing of these injuries. Very common in explosive athletes, sprinters, basketball players, people that do a lot of jumping. This is one of the injuries that can be very challenging to diagnose. Patients usually complain of this really kind of vague medial foot pain, ankle pain. Studies have shown that it can take up to 6 months to actually reach the clinical diagnosis for this. X-rays don't usually show a lot until they've kind of progressed fairly far into fracturing the navicular, and so maintaining suspicion is probably the biggest thing to help pick these up. The most specific thing to identify them is this exam, tenderness at the end spot here, which is marked, that X is kind of right over the dorsal medial aspect of the navicular. So it's just past the ankle joint. And they tend to have tenderness there on exam. Treatment for these, non-operative treatment historically has been non-weight bearing in a cast for 6 weeks, similar to metatarsal base fractures. Several studies show increased treatment failure with a weight-bearing cast, and so really it's keeping patients off of them. Operative treatment tends to be open rupture internal fixation with cannulated screws plus or minus graft, similar to fixing fifth metatarsal base fractures. In this study that followed 10 patients that had navicular stress fractures, they achieved union in 80%. The 2 that didn't heal, that were treated surgically, actually had both complete fractures that were displaced at the time of presentation. So maybe a little bit different injury than most of the ones that we're typically seeing in clinic. But post-op, non-weight bearing for 6 weeks, progressive weight bearing in a boot for 6 to 8 weeks, and then weight bearing, and it's tolerated in the boot at 8 weeks and weaning out. This is one of the injuries that prior to letting anybody actually return to sport, I will get a CT scan to document complete healing. I think anybody who has treated these long enough will have a story of one that looked completely healed, and after getting back to sport, kind of symptoms came back and they have gone on to refracture or have failure of their treatment. And so a little bit slower kind of getting these patients back than other injuries. Sesamoid stress fractures. So sesamoids, you have 2 sesamoids. They're right underneath the big toe joint. They're in tendons. They present with plantar pain at the big toe, kind of the hallux MP joint. Very common in runners, football players, and gymnasts, people that are pushing off with good force off of the big toe. Important to differentiate from a bipartite sesamoid, which can be normal in 5 to 30% of the population. Most commonly, these occur in the medial sesamoid, so on the inside part of the foot, because that bone's a little bit bigger. Treatment, non-weight bearing in a cast that extends out past the big toe because you need to immobilize the joint, and then transitioning to a carbon fiber plate or stiff orthotic. These can do reasonably well with non-operative treatment. They're just immobilized just kind of for that 6-week period. If they do go on to need surgery, you can fix them or kind of excise the bone and advance the tendon, and most patients do pretty well with that. Malleolar stress fractures. And so medial and lateral malleolar stress fractures are probably less common than some of the other injuries that I've talked about, but certainly do occur. I've seen these more in patients that have underlying deformity. And so patients that have plano valgus or kind of that flat-footed deformity tend to place more stress on the lateral aspect of the leg and are going to be more prone to lateral malleolar stress fractures. Patients that have kind of cavo-varus alignment or have varus distal tibias and kind of have that tilted in appearance of their foot place a lot of stress on the medial side, and they get these shear medial fractures. And so you can see that vertical split. And these are the ones that are more unstable that we worry about a little bit more. Non-operative treatment in a cast or boot, kind of 6 weeks, similar to the other injuries we've talked about, with the transition into shoe wear as symptoms allow. If they have a flexible deformity, you can try and use orthotics or wedges to correct their underlying deformity and see if that helps prevent symptoms. But if they, particularly on the medial side, if they come back, oftentimes we'll talk about surgery to fix those. Operative treatment for non-union or high-risk patterns, such as those vertical shear fractures. In another study out of this, out of the group here, they found faster return to sport and quicker resolution of symptoms with fixing these surgically. Calcaneal stress fractures. This is one that's commonly tested in medicine, and it's almost always the same stem. It's a military recruit or somebody who's really kind of increased their long distance runs recently. This is more often missed because of all of the other common causes of heel pain that just kind of get lumped into a bin, whether it's plantar fasciitis or Achilles tendonitis or other diagnoses that can delay diagnosis of this. The most sensitive test for kind of looking for this is calcaneal, like a calcaneal squeeze test. So if you take the heel and kind of just squeeze it between your palms, it causes pain like deep in the bone itself. And really with plantar fasciitis or Achilles tendonitis or other pathologies, that shouldn't bother them. Those are more point specific at the insertion origin of those tendons or fascia. And so squeezing the heel will kind of be the most sensitive test. Responds well to immobilization in a boot and activity modification. I think lastly, metatarsal stress fractures most commonly occur in the second and third metatarsals. They are the longest metatarsals, which you can kind of get a hint of on this x-ray, and they're subject to the most stress. Again, higher risk populations are runners, military recruits, dancers, and basketball players. Protected weight bearing and a post-operative shoe with activity modification has been the mainstay of treatment. Most patients with these are able to get back to activities and kind of return to sport between 6 and 8 weeks, depending on symptoms. A lot of times I will put the carbon fiber plate or something to really stiffen up the shoe wear of these patients and athletes, because it can help offload the metatarsals more as they get back to activity. I think that is it. We'll open up for questions if anybody has them.
Thanks, Dr. Wohler. Really good presentation. Without looking at the chat function, I put a question out to the group. The trivia question is this: name a high-profile basketball player who early in his career had a navicular stress fracture.
Is this for me or for the group?
It's for you.
Michael Jordan.
You got it. Okay, very good. You passed. He was a little bit more aggressive with his recovery than his team wanted him to be. He was a very, highly sought after athlete, and they wanted to take it really slow. He actually was playing behind their back, pickup basketball back in North Carolina before the team knew he was playing. So he went behind the doctor's back and was doing stuff that was against their recommendations. Anyway, kind of fun story. Dr. Wohler, tell me again, what is your highest risk patient? What do they look like to develop a stress fracture? You need your mic on, please. While we are searching for audio fixes, I will answer that for him. he had mentioned his,
Yeah.
oh, there you are.
Scott, can you hear me?
There you go.
Yes.
Yes.
Okay. I'd say, a lot of it is going to be kind of that history that I mentioned, right? It's somebody who has recently picked up a new sport, recently really increased their training, kind of subjecting the bone to new stress, and I think thinking about the reasons why somebody may have less than optimal bone healing are also important. And so, female athletes can be more prone to these. Female runners that may have caloric requirements that are not being met, and kind of that, like I mentioned, the female athlete triad have a fairly high suspicion for stress fractures if those patients and athletes are coming in complaining of pain. I didn't cover this because it's not something I see quite as often in my practice, but femoral neck stress fractures are also very common, particularly in young female athletes and runners, and they can also be problematic. So hip pain is another location that will commonly see stress fractures, and that you want to have a high clinical suspicion to maybe get those patients evaluated if they're having this kind of vague activity related pain in any location.
So this is kind of where the rubber meets the road, right? For the people interacting with these athletes is, one, how do we determine when a coach or a trainer or a parent should be concerned about pain to seek out imaging or somebody else to look at it? And two, how do we prevent our athletes from getting in this situation, right? Because we know that high intensity volume and quick ramp up can lead athletes into this. And I've seen plenty of patients even in marching band, right? So maybe some of the kids that aren't doing a ton of running, but are still doing a lot of walking, like we might see in the military population with pounds of equipment, can lead them into this. So how do we as a group develop something that allows kids to have a slow ramp up period moving into their season?
I mean, I think you've kind of hit the nail on the head there. It is developing the system so that you're not going to full intensity right away and ramping up. And, I played football, so, football is kind of the thing that I think of most, but it's like, you don't go to full pad 2-day practices every day for, 4 weeks. It's like, all right, mornings full pads, afternoon shells, or you do something to kind of decrease the stress and, decrease, what you're doing. You have some downtime, and you're not kind of ramping up like you're getting, in season training right at the beginning of the season. For parents and for coaches and just kind of for suspicion and, how do we work these up, right? It's common for athletes to come in the middle season that have pain. And so I would say anything that is not improving, anything that, if you take a break and go back to it, you get the same pain that is very much activity specific and kind of load specific, are reasons to kind of maybe raise red flags and say, do we need to take a closer look at this?
I want people to realize that bones are dynamic structures in the body. Bones are not like stone, right? I think some people have the concept that the bone is the bone, it's super hard, but there are living cells in the bone, and our bone remodels towards the stress load that is applied. So if somebody was not a running athlete before and they go, you know what, I'm going to run a marathon, and they go from running minimal to starting a training program that puts them at 5 miles a day, they're going to be at excessive risk of developing a stress fracture because their bone hasn't had time to remodel to the stresses that are applied. And so I think that just general concept is important, and that may need to be individualized to each person. You're going to have athletes that are year-round athletes, always doing something, running, always involved. They might be slightly less at risk for certain stress fractures, but more at risk for those that are more explosive movements, right? And you have other athletes that maybe you just need to decrease their volume and intensity early on in the season and do a slow ramp up. I've got an interesting question for you. I think surfaces that we play sports on have changed, and we're on a lot of artificial surfaces now. Do you know of any data or suggestion that that could increase risk for stress fractures?
I don't know of anything specifically related to stress fractures. I know that there was some data when we were more on the AstroTurf, kind of the concrete and just hard surface on top. I mean, that's where like turf toe and some of those injuries really started creeping up more, was when we had the transition to AstroTurf. To my knowledge, there hasn't been a great study looking specifically at stress injuries on kind of the modern field turf surfaces. But yeah, you're not wrong. It'd be a good, interesting thing to kind of know.
Going along with that, one thing I sometimes talk about my patients too, especially with running, is considering different surfaces to run on. I think concrete is the most unforgiving surface that we have, and most of our runners run on streets and concrete. Do you think there's a place for more turf running, soft track running, cross-country type training, even treadmill? What do you think about that stuff?
Yeah, absolutely. I think for runners in particularly that can be useful. You think about it, it's a variation of cross training, right? You're just exposing yourself to different types of training that are going to subject the body and the bones, like you mentioned, different stresses, and hopefully not overload any one specific location. And so not something that I know that there's an abundance of data on, looking at running on different surfaces and specifically related to stress fractures. But you're right, concrete's probably the worst thing to run on. Treadmills, at least most of them have built in a little bit of kind of recoil and give back to them. Grass and trail running is great. Watch out for sticks and rocks on the trail. You might be coming in with a different injury.
Yeah, plenty of mole holes down in Bloomington, tell you that. What are your thoughts on footwear? Footwear, custom insoles, should every athlete runner be thinking about these things, or only when and after they're having a problem?
That's a great question. I probably have a little bit different thought on custom orthotics than most. So I use custom orthotics in my practice to correct deformity primarily. So patients that have flat foot or a high arched foot, kind of cavovarus foot, that is leading to symptoms. Those are patients that I'll consider using orthotics for. And the point of the orthotic is to try and correct the deformity to offload one way or the other. Patients that have just kind of generalized foot pain, I usually recommend try a well-cushioned over-the-counter orthotic first. Custom orthotics, most patients are going to spend $300 to $500 out of pocket. And if you haven't tried an over-the-counter orthotic, to be sure that you're going to like something different in your shoe, that's a great spot to start.
We're not here to push one brand or the other, but I mean, do you point people in a certain direction? Do you have a brand or a line that seems to fit needs the most?
The Atrix ones I've found good success with. I mean, I think people going and just trying Dr. Scholl's is great. I think Superfeet seems to make a kind of full line of over-the-counter orthotics too. Really, most of the time, if you go to a good shoe store, like a running shoe store, they're going to have different inserts, and you can take them out of the package, feel them, play with them, see what you think is going to accommodate your foot the best. I feel probably the most important thing, and what we see most of, is good supportive shoes, right? If you have a shoe that you can take and just completely bend 90 degrees through the midfoot or in the toe, that's going to subject your foot to a lot of stress. And so those are areas where we see metatarsal stress fractures. And sesamoid stress fractures because you have all that bending force that's being applied to the bone. And so, more rigid shoes, I tell patients that have metatarsal pain or midfoot arthritis or other things where they're having stress on their foot. Hoka's are great, New Balance are great, Brooks, Asics, kind of shoes that have they're a little bit more sturdy and supportive. If you're going to be running, particularly, those are great brands to go with. Obviously, for some sports like soccer, the cleats are going to be a little bit more flexible, and you somewhat have to just make do with what you have. But understanding, I'll usually push people towards something that's a little bit more sturdy as opposed to a super flexible shoe, and when their sport can accommodate it.
Okay. Maybe just a couple more comments here, and then we'll wrap up. We had a question, what's your take on cross-training shoes? You mentioned inserts for shoes, but ensuring you change shoes every so many miles. Any comments on those 2 points?
Yeah, I mean, that is, I think if you do a lot of running, you need to be cognizant of how many miles you've actually run on your shoes, because they do lose their support. And it will vary by shoe. If you have a light shoe that you're running races in, you may only get 100 to 150 miles out of it before you need to start thinking about replacing that shoe. And so a lot of it more has to do, if your foot starts hurting and you've had the shoe for a long time, I think it's time to maybe consider upgrading it. But I mean, I think cross training in the sense of, if you have different types of shoes, you can certainly wear those too, and you're subjecting your foot to different kind of stresses. But
yeah, no, I think that's perfect. Last comment, we don't need to get too in detail, but you brought up the female triad, and I think a lot of our female athletes are at risk of developing these type of stress fractures in the lower extremity, and we need to be very mindful that females are at risk for eating disorders, being underweight, not having enough caloric intake. This can affect their menstrual cycle. It can affect their bone mineral density. It can affect their mental health. And so I really think that group of athletes, we need to have our flags up a little, right? We got to have our antenna up to catch these things early on. And stress fracture is just a part of that, but we really need to make sure those athletes are getting enough calories and are at a healthy weight.
I think I particularly in female or patients that are at risk, it's important to ask those questions, right? Because a lot of times they can come into clinic and nobody's asked, are you having regular cycles, and what is your caloric intake, and trying to just keep your antenna up for eating disorders. You're right, it's very important. I think easy to overlook as clinicians or as coaches or as athletic trainers and people that are caring for these athletes, but they're not the easiest questions to ask, but they're important questions to ask.
Yeah, absolutely. Okay, I think that's our time for today. So I just want to say thank you to Dr. Wohler for being our guest today and providing some great information. I hope everybody found this beneficial. Maybe learned something, maybe you got to bring some knowledge that you haven't thought about for a while to the forefront of your brain. Again, we will be sending out evaluation forms. Really ask you to fill those out. We'd love to hear feedback of how you've liked these webinars, or what you would like to see different, as well as possible topics for the future. So we will once again be sending out invites again for our next one in December, and hope to see everybody there. So have a great day. Thank you.